Hello, and welcome to our live webinar from the International Society of Cardiovascular Pharmacotherapies A to Z CV Pharmacotherapy Series. This activity is organized in collaboration with our friends from the Anticoagulation Forum. Both organizations are very near and dear to my heart, and I'm very excited and very proud of this collaboration and this partnership that the two organizations have entered. In today's session, we're going to hear a powerhouse activity related to anticoagulation stewardship. Let's start a global revolution. Here we will provide you with essential insights and practice tools to elevate your understanding and application of anticoagulation therapy and efficacy and safety worldwide. My name is Craig Beavers, Dr. Craig Beavers. I'm a member of the ISCP Board of Directors, the ISCP Governors for the United States of America, and co-lead of the Educational Programs Working Group. I'm assistant adjunct faculty with the University of Kentucky College of Pharmacy and a cardiology clinical pharmacist and professional lead for the CV service line for Baptist Health System. And it is with great pleasure that we are joined by a fantastic faculty today of global representation. First, I'll introduce our main speaker, Dr. Allison Burnett from the United States of America. Dr. Burnett received her pharmacy doctorate from the University of New Mexico College of Pharmacy in 2003, then completed a general pharmacy practice residency at Boston Medical Center in 2004. She now serves as the lead pharmacist in inpatient antithrombosis stewardship program at the University of New Mexico Health Science Center and has an associate adjunct clinical professor at the University of New Mexico College of Pharmacy. She has published more than 40 peer-reviewed articles and book chapters on anticoagulation, thrombosis, and bleeding management, has presented on these same topics at numerous national and international conferences, and is a leader within the Anticoagulation Forum. She sits on the National Certification Board for Anticoagulation Providers and, as I alluded to, has the distinct honor of serving as the current president of the Anticoagulation Forum. Hello, Dr. Burnett.
Good morning, Dr. Beavers. Thank you for that introduction.
Thank you. We're also joined by an outstanding panel. We have Professor George Andre Dan from Romania, a senior member of the executive committee of the ISCP, also past president of the society, the distinguished professor of medicine and cardiology and internal medicine at the University of Medicine Carol Davila in Bucharest, Romania. He is an honorary member of several national and international societies, a senior consultant and researcher at Colentina University, and he will be one of our panelists for today. Hello, Dr. Dan, and excited to have you from your perspective from being a cardiologist and electrophysiologist.
Glad to meet you. Glad to meet this team.
Good. And also joining us today from Australia, Mr. Hadley Moritz. Hadley is a senior clinical pharmacist for anticoagulation stewardship at Alfred Health. He completed a clinical pharmacy fellowship in malignant hematology and bone marrow transplant in 2014 and has a strong interest in evaluating systems that support quality use of anticoagulation and improve patient-related outcomes. He's a member of the Thrombosis and Hemostasis Society of Australia and New Zealand, and he will also be one of our panelists today. Hello, Mr. Moritz.
Thank you, Craig, and good evening, everyone from Australia.
Right. This webinar is an independently activity run by the ISCP in collaboration with the Anticoagulation Forum. Any supporters have no influence on the content of the program. This will be an interactive session that will feature a panel discussion with a live Q&A segment, and we're going to do a little bit of the Q&A and discussion after Dr. Burnett speaks, and then after we do some of the case discussion. So we'll have plenty of time to provide questions and opportunities. So please submit questions to the faculty via the web chat box, and we'll endeavor to answer as many of these questions as possible at any time during the Q&A. So let's get started. This is the agenda for the day. Please note that a certificate of attendance by ISCP will be issued to those who complete the post-webinar survey, and send a request to email or by email to Lourdes Marcinko, ISCP's coordinator, and you can see her address below listed on the sides. Before giving the word to Allison, here's a quick reminder of today's learning objectives. We're going to unlock the secrets to optimizing patient outcomes, learn effective anticoagulation stewardship, or how it minimizes risk and maximizes therapeutic success. We're going to get global insights and local solutions and discover regional challenges and successes and why a unified global approach is key to improving care. We're going to boost patient adherence and prevent adverse events, which are ways and strategies through anticoagulation stewardship to dive into proven strategies to enhance patient compliance and reduce complications in anticoagulation therapy. And then your practical takeaways you can implement immediately. You leave with actionable strategies to lead to how you can maybe evaluate starting anticoagulation stewardship practices within your own institutions at this time. So I'm going to now turn it over to Dr. Allison Burnett to jump into this conversation. Thank you.
All right. Well, thank you so much, Craig. And welcome to all attendees. Good morning, good afternoon, or good evening, depending on where you're joining us from around the world. And I want to be sure to thank ISCP for this important opportunity to share this international platform to amplify our call to action for anticoagulation stewardship. So over the next 20 minutes or so, we're going to explore several areas, including why anticoagulation stewardship is urgently needed. We're going to discuss what anticoagulation stewardship is. We'll also explore how clinicians and institutions can approach the development and implementation of anticoagulation stewardship initiatives. And then finally, we're going to take a look at who are the key players to wider spread adoption and implementation of anticoagulation stewardship around the globe. So let's take a look at some data from different areas around the world that help us understand why anticoagulation stewardship is so urgently needed. And we can start with some data from the United States. So here I'm showing you some data from the United States Centers for Disease Control and Prevention. And what this graph is reflecting is data that's been reported over the last couple of decades, showing the top classes of medications associated with adverse drug events severe enough to lead to an emergency department visit. And what I'm highlighting for you is antimicrobials in green and opioids in blue. And the reason I'm doing that is that these classes of medication have received a significant amount of federal level attention here in the United States in the form of strategic action plans or mandated stewardship programs to reduce harm events. And you can see that over time, adverse drug events have actually decreased in these areas, which suggests that stewardship is a very viable care delivery model. However, if we look at anticoagulants, we see a much different trajectory, and we see that these adverse drug events continue to rapidly increase and now account for more than 20% of these emergency department visits. And unfortunately, this is despite the availability of the direct oral anticoagulants, which were designed to be safer and proven to be safer than more conventional anticoagulants, such as vitamin K antagonists, in several large randomized controlled trials. And you can see in the graph that around 2014, anticoagulants actually surpassed antimicrobials to become the leading class of medications associated with adverse drug events. And so this has been the situation in the United States for more than a decade now. And I think it's surprising to many of us that more attention hasn't been called to this. And I think also concerning is we know this isn't confined to the DOACs, and we know it's not confined to the emergency department. It's happening across all care settings, and it's actually happening across the globe. And so what we see in this recent, sorry about that, we've got a little delay in our slide advance. What we see in this recent systematic review and meta-analysis that included 32 studies conducted within 13 hospitals in North America, the European Union, and also the Middle East, is that up to a third of all DOAC patients have some type of prescribing error associated with their therapy. So this represents a huge opportunity to provide better care and promote DOAC stewardship. And I do want to emphasize for attendees that these adverse drug events aren't always just, benign events where maybe somebody's perhaps getting one or two inappropriate doses. Sometimes these events can be actually fatal. And so this was an interesting analysis out of England and Wales looking at coroners' reports for anticoagulant-associated deaths among cardiovascular patients. And so in these countries, when a death is deemed potentially preventable, the coroner is required by law to file what's called a PFD report, or a prevent future death report. And the intent is really just to figure out ways to make medication use safer and more effective. And what you can see from the quantitative analysis is that there's several failure points that likely contributed to these anticoagulant-associated deaths, including failure to follow protocols, poor communication and documentation, and suboptimal clinician education and training, among others. And I just think this represents a real opportunity for us to critically examine how we're delivering care to these patients. And encouragingly, we're starting to see more of this type of harm data emerge from various areas around the globe. And we're going to hear more about this from our esteemed faculty later in the webinar. So a number of years ago, the Anticoagulation Forum actually adopted anticoagulation stewardship as our leading strategic initiative for a multitude of reasons, including the fact that there are already millions of patients around the globe that require these high alert yet essential therapies. And we know, based on population estimates, that the number of patients requiring anticoagulation is going to at least double and possibly triple over the next couple of decades due to secular trends in the population, such as aging and obesity. And we clearly see that anticoagulant or antithrombotic care is getting significantly more complex with expanding indications and expanding populations. And there's already more anticoagulants looming on the horizon with the factor 11A inhibitors. So we clearly see this as a perfect storm that's going to require doing something above and beyond what we're currently doing, because that's clearly not working. And so what this is going to require is more comprehensive, more sustainable, and more intensified efforts around anticoagulants in the form of stewardship. So what exactly is anticoagulation stewardship? Well, simply stated, it's ensuring the application of best clinical practices using multidisciplinary holistic approaches that span the entire continuum of care, and really focuses more on disease state management rather than anticoagulant drug management. And importantly, this has to be done in tandem with continuous quality improvement, where we're constantly looking for deficits in our systematic processes and opportunities for improvement, and assessing the impact of our efforts so that we are ensuring best use of our stewardship resources. And then very importantly, stewardship prioritizes our patients' values and preferences through shared decision-making, because we know that the best anticoagulant for a patient is the one that fits best with their lifestyle and that they can be adherent and persistent with. So when we adopted anticoagulation stewardship as our leading initiative, we realized we had an excellent blueprint to work from the antimicrobial stewardship realm. And so we've leaned very heavily on this highly successful model around antimicrobials that has been adopted and embraced around the world. And we've laid out the same important milestones that you see here, but because of the severity and magnitude of harm events that are happening with anticoagulants, we've been working on a much more compressed timeline. And so over about the last 5 years, we've been able to partner with key governmental quality and clinical organizations to develop several resources around stewardship and generate really meaningful momentum to help us get to our ultimate goal, which is actually a national level mandate requiring anticoagulation stewardship programs in all hospitals, similar to what's been mandated for antimicrobial stewardship since 2019 here in the United States. And most recently, we held the first ever National Summit on Anticoagulation Stewardship in Washington, D.C., that brought together more than 20 stakeholders from key organizations and entities. And really, the point here was to amplify the concern around this health crisis that we're seeing with anticoagulant associated harm, and recruit a broader array of voices to help us drive that momentum. And so we've written a white paper on this that you can access at the Anticoagulation Forum website. So we encourage you to check that out. I want to pivot now and just talk about how clinicians and institutions can approach the development and implementation of anticoagulation stewardship initiatives. And I think one of the most important points to start with is that you don't have to start from scratch. As I mentioned, the Anticoagulation Forum has been doing a lot of work around building resources, including the core elements of anticoagulation stewardship, a very detailed implementation playbook, and then several advocacy resources that highlight successful stewardship initiatives across the United States. And all of these can be downloaded for free at our website that you can access via this QR code. And they serve as really nice talking points to initiate or further conversations with your leadership around stewardship. And a question that we always get, from people who are interested in implementing initiatives or programs is, well, how do we get started, or how do we do this? And I'll just say that this is going to look a little bit different for everyone, particularly, I think, here in the United States with the structure of our healthcare system. But I think a model that I've adopted and that I gravitate to is keeping it very simple and thinking about the ABCs of stewardship. And this simply stands for aligning with leadership, building a pilot infrastructure, and then checking the impact of implementation. So to drill down on this a little bit, it is absolutely an essential first step to align with your leadership, because this is needed for support, a sustainability, and success of any initiative. And so there are a number of ways that individuals can align with their leadership. This may be around budgetary issues like inappropriate use of high-cost therapies, or it could be around known patient safety issues within a hospital system. Regardless of what the alignment point is, the overarching tone of the conversation with the leadership should be, help me so that I can help you reach your objectives for this practice site. And then from there, you need to build the pilot infrastructure. And again, this is going to look different across different clinical practice sites because of differences in resources, differences in clinical needs, et cetera. So you really need to think about right-sizing the initiative to your specific care setting. And then from there, getting some baseline data, building a multidisciplinary team that can start out very small and can grow over time, and then making sure you have an implementation timeline to keep you on track and help you assess your progress. And then lastly, C is checking the impact of implementation. You want to make sure that you effectively analyze your data and share that with your leadership. And if there's positive results, use that to your advantage to negotiate for additional dedicated resources for a next pilot initiative to expand your stewardship efforts. And then lastly, we want to encourage everyone that's working on initiatives in this space to publish your results, because we really need to work on building the body of literature that demonstrates the feasibility and utility of stewardship implementation. So I'm going to pivot now, and I want to show a few really nice examples of stewardship initiatives that have been published in the literature, and they're focused around two large areas of opportunity for improving anticoagulation care, and this is around DOAC optimization, and then we're going to touch on antiplatelet de-escalation. So starting with DOAC optimization, it is relevant because we know that a large number of patients are on inappropriate or incorrect DOAC therapy. Pharmacists within the Veterans Administration health system here in the United States have very successfully addressed this through the use of innovative DOAC population health dashboards. And so by using logic and information from the electronic health record, they're able to quickly identify DOAC patients that may be on inappropriate therapy and require interventions. So these innovative tools have been implemented in more than 90% of VA ambulatory clinics here in the United States. And because of increased efficiency, a single pharmacist is able to oversee hundreds, sometimes thousands of DOAC patients. And they've published results, impressive results, that show that pharmacists have tripled the number of interventions, and it's taking them about a quarter of the time it previously did prior to DOAC dashboard implementation. And I think in addition to all these process measures, what's really notable, and I'm showing you the publication to the left here, is that they've also been able to demonstrate that use of these dashboards leads to a reduction in clinical outcomes, patient-important outcomes of VTE, ischemic stroke, and bleeding. So a really nice example of a stewardship initiative. And it would be great to have population DOAC dashboards in all care settings, but these tools, do require time and resources to build, so it's not likely that everyone is going to have them from the outset. But there are several nice published initiatives in the literature that demonstrate alternative ways to affect DOAC optimization. And so, for example, at the University of Maryland Medical Center, they implemented an inpatient pharmacist to dose DOAC protocol and were able to reduce DOAC prescribing errors by almost half. At Brigham and Women's Hospital in Massachusetts, they incorporated DOACs into their outpatient antithrombosis clinic and found that more than a third of patients benefited from pharmacist interventions to optimize their DOAC therapy. And then lastly, at the University of Michigan, ambulatory care pharmacists there were not only able to optimize DOAC dosing, but they were also able to improve patient adherence with their DOAC compared to usual care. So all really nice examples of how this can be done, and it can be done right-sized to the practice site. Okay, let's talk briefly about antiplatelet de-escalation, another big area of opportunity for us. We know that evidence and guideline recommendations are changing around antiplatelet therapy, particularly among patients who also need concomitant anticoagulant therapy. And we know combining these therapies leads to increased bleeding. And so I think, primary cardiovascular prevention is one of the biggest areas in this regard. And so I think it's a very relevant conversation for members of ISCP. So let's take a look at a few initiatives that have been published. This was a very large-scale initiative that was done across 6 anticoagulation clinics across Michigan. And what these investigators did was they used system-level processes to identify patients that were on both warfarin and aspirin. And then they leveraged multidisciplinary conversations to identify patients that could be have their antiplatelet de-escalated because it was not clearly indicated. And you can see that over time, the proportion of patients that were on combined therapy decreased. So again, an improvement in a process measure. But more importantly, what these investigators were able to show is that this reduction in combined therapy led to statistically significant reductions in both major bleeding and emergency department visits. But again, stewardship can be done anywhere and essentially at any scale. And so what I want to show you here are some much smaller single center initiatives around antiplatelet de-escalation. And in fact, some of these were driven by pharmacy residents, but they still relied on those same stewardship principles of using system level processes to identify these patients, multidisciplinary discussion with the prescribers, and also shared decision making with the patient and family, but led to significant reductions in patients on dangerous combined therapies. Okay, I want to just comment on some thoughts about who is going to be integral to the wider spread adoption and implementation of anticoagulation stewardship around the globe. And I think, you know, the Anticoagulation Forum, we've been leading the charge from the local to the national and now even the international level. But what we've realized is even though we're a very impactful organization and we're very dedicated to this initiative, we can't do this alone. And that's why we're reaching out to other entities and organizations and individuals to help us drive meaningful momentum around this. And that's why we're particularly appreciative of organizations like ISCP to help carry this load and help us get to goal on anticoagulation stewardship. There's an African proverb that says, you know, if you want to go fast, go alone. And if you want to go far, go together. So we're really intent on finding ways to partner with other entities to help us go farther with this. As a pharmacist, I wanted to take just a minute to highlight a couple of publications that just showing the impact that pharmacists are having in this space. So there was we're starting to get enough of a body of literature around this that we can actually do systematic reviews and meta-analyses. And this is just one example. And what this paper showed was that compared to usual care, pharmacist-led interventions on anticoagulants result in increased appropriate use of anticoagulants, and that is associated with a reduction in harm events in the form of bleeding or thromboembolic events and even hospitalization. So pharmacists are clearly going to play an integral part in driving anticoagulation stewardship, and in fact, they already are, as evidenced by this paper. And the Anticoagulation Forum recognized this, and again, leaning heavily on that antimicrobial stewardship model, they too, in their antimicrobial stewardship efforts, developed advanced training opportunities for pharmacy residents, which turned out to be a catalytic move for wider spread adoption and implementation. And so following suit with that, the Anticoagulation Forum has been able to help support the launch of nearly a dozen specialty pharmacy residencies in thrombosis and hemostasis with the intent of developing anticoagulation stewardship specialists to drive these programs and champion these initiatives as more and more of these programs come online. So the key takeaways from this introductory session were stewardship is a proven care delivery model, and there are lots of anticoagulation champions all across the globe that are working hard to develop and implement approaches to better patient care, but it's an extremely heavy lift, and it's being done more in a piecemeal fashion than a widespread methodological fashion. And so what we need is increased collaboration and momentum that supports this call to action for anticoagulation stewardship. And I think it's clear that this isn't just essential for patient outcomes, but I think it's essential for the overall viability of healthcare systems around the world. With that, I'm going to pause and I'm going to turn it back over to my colleague, Dr. Beavers.
Thank you. And we'll take a few minutes to address a couple questions, and we'll look at this practically. And I see Dr. Dan has some questions. I'll let you go ahead and start. Nope. Can you hear us, Georgie? Yep.
Yes. First of all, I would like to congratulate Dr. Alison Barnett for the fantastic lecture. Second, I would like very shortly to discuss a little bit the empty part of the glass. Not necessarily because I want to relieve contradictions, not at all, but to make very clear that the unity could not be obtained another way than with diversity. So the first question, the first issue I have in my mind, if the idea promoted by Dr. Allison, by the idea of stewardship, is a valuable idea. And the answer is absolutely yes. Absolutely yes. The second question is, it is at this moment generally applicable because stewardship, this is the main virtue should be the general applicability. And unfortunately, my answer here is more reserved. Probably not. And why? Because our systems are very different. What is applicable in the United States system is absolutely not applicable in many European countries. I give you only one example. The power of decision of the clinical pharmacist, if he or she exists, is very limited in Europe. In many countries, there are some in which the clinical pharmacist has a decision with the same power like in the United States, but this is not the majority of the countries in Europe. So this is a limitation. Second, the repartition of the coagulation centers is very different among the countries. It is very known that in other countries, there is a very, very solid implementation of the coagulation center. But in other countries, including mine, for example, this is a very weak implementation. Last in this chapter, but not the least, it's a plethora of strategies imposed now by different chapters of our practice. I counted 8 with the name ABC. So for the clinician, could be a little bit difficult to be aligned with all of these skills. And lastly, at this chapter, the contribution of the clinician, especially in the countries where the clinical pharmacist has not the top expertise, like I understand it is in the United States. So the contribution of the clinician should be major in the conception of such kind of stewardship. The second point is a very short. It was absolutely clear, I think, in the presentation of Dr. Allison. And I apologize, but I want to emphasize one thing. When we are talking about the necessity of the stewardship, when Dr. Allison told about the increase of the number of adverse effects because of anticoagulation, please do not take in account only the excess of anticoagulation, so the bleeding, because a low dose has the same severe and important impact on practice. And unfortunately, if we try to analyze at this moment, because there is a Latin proverb, curat causas tolitur effectus, if you are curing the cause, you are obtaining the effect. If we try to analyze the main bad things happened with the anticoagulation in the clinical practice, I will find 3 the most important. The first is a bad dosage, as Professor Barnett said already. And at least after my experience with several registries where I was involved, here, because doctors are afraid of hemorrhage, the most thing which is happened is an underdosage and not the overdosage. So we have a lot of patients with a low dose of especially DOAC, even if there are very clear indication for a low dose. The second is what was already emphasized by Dr. Allison, is a bad control of the patient. So instead of curing atrial fibrillation, we should understand to cure the patient with atrial fibrillation, so to control the hemorrhagic factors or comorbidities as so clear in the Hasbet scale. And last is adherence. Adherence is very important in anticoagulation, and the studies demonstrated that the intentional non-adherence, it means which is dependent of the patient, is very important. And it's very important because of the bad effect of the media on the knowledge of the patient. The patient is reading, he is not satisfied with adverse effects, and maybe this is one of the explanations. And last, I should make very clear that even we have a global, a holistic approach, and I fully agree with this, our last target is a personalization of the therapy. So it is the end now of a part of the evidence-based medicine which deal with globalization of the treatment. It is now the moment to find everything to personalize our treatment to our patient. Thank you.
So I'll let Allison or Hadley jump into that. I think a lot of good points there. I think to his point, Dr. Burnett, one of the big ones is obviously there is variability in terms of pharmacist scope and breadth in globally, but I think the concept is definitely not just limited to pharmacists. Do you want to kind of explain or provide your insight into the crux of how to make this work?
Yeah, happy to, and really excellent comments, Dr. Dan, on all points. And I will say that yes, I agree. The anticoagulation forum, as I mentioned, has recently spread our wings a little bit and moved into the international space, and we're starting to have more conversations and learn more about what this looks like around the world. And Dr. Dan is on point when he says that primarily pharmacist-driven initiatives wouldn't be the norm in other countries. And I think my response to that is, we need to figure out what the best model is to optimize care delivery. We also need to think about empowering all clinicians around this. And I'll mention we recently conducted a survey, the results of which I think will be revealed at an upcoming conference. But in those survey responses, it validated exactly what Dr. Dan was saying, is that in many countries, pharmacists aren't even involved in this process, and often DOACs aren't the leading class of anticoagulants that are being used. There's still many countries that are heavily reliant on warfarin therapy. And so again, to his point, optimization of those therapies is essential as well. So I think there's lots of room for improvement across the board, and we're just starting to scratch the surface on this, but that's why it's so important to have these types of conversations so we raise our collective awareness about how to move forward.
Yeah, and if I totally agree. If I can jump in, Craig, and agree with the points made by Professor Dan and from Alison. I mean, obviously a key challenge here is the potentially lack of consistency from institution to institution, from country to country, state to state, across the globe in implementing these programs. And whilst I think and biased here that clinical pharmacists are a very good resource to champion some of this change, to be involved in therapeutics and medication management, optimization, review of literature relating to this, and putting in processes in place. There's obviously going to be variation in clinical pharmacy expertise and resource and availability from all these different networks. But that's not to say that these stewardship programs can be a system that's put in place by whomever or whatever team is in charge of driving that forward, whether that be putting policies or guidelines in place or starting with one project to look at improving a system within the organization, and it drives from there. In fact, I was just reading, came across an article published in a hematology journal just today, where there are no clinical pharmacists within the institution. This is in the Canada hospital, or limited thereof, and small resource, some pharmacists with a hematologist involved to improve anticoagulation management. So it can be done. And then to link back with Alison's point, I guess, is, well, which comes first? And if there can be more driving of this need for change and having mandated regulations or requirements amongst higher level organizations, institutions by country, then that will drive the sort of funding or the resources, as long as there's expertise available, to have those systems in place as sort of a standardized program.
Yep. So I think just for the sake of time, and we can continue to hash out these points, and there's some great commentary and in the Q&A I'll read shortly. I think the clinical cases will provide a good conversation point to some of these points. So, and there's kind of nothing disclose this, but we'll talk to learning points. So I do want to point out the reference, and it's down here on the article, but these are not necessarily my cases. This is a great article from some peers from the Anticoagulation Forum that have written some cases examples, and they actually, it's a great article to pull to provide additional context on this and this whole conversation. So I kind of did this intentionally and used their cases nicely to point back to some other examples of anticoagulation stewardship. But this is case one. You have her new stroke, a patient that, let's see, I may have skipped
I think
a
you need to go
slide
back
here.
one
Go
slide,
back.
Greg.
Yep. I can't go back for one. Well, I'll read the context for the sake of time. I have this other slide pulled up because it's not wanting me to go back. But essentially, this is a 62-year-old female, 72 kilogram female with new ischemic stroke. She has a history of coronary artery disease, drug-eluting stent placement 6 years prior. She has a chronic kidney disease with 1.6 milligrams per deciliter, or a creatinine clearance of 35 milliliters per minute, and a history of atrial fibrillation. So again, coronary artery disease, a stent 6 years ago, drug-eluting stent, CKD with a creatinine clearance and AFib. And her home medications includes, and this is kind of a point alluded to by Dr. Dan, is home medications include apixaban 2.5 milligrams twice daily for primary stroke prevention. And then, there's the slide. And you go to the next slide. For some reason, it's not letting me move forward. I don't know if someone else can move forward for me. If you go to the next one, you can see that she had a new stroke that was, quote unquote, by the team deemed to be a failure of apixaban. And so they switched the patient to warfarin, and low dose aspirin is added given her coronary artery disease history. And then 4 weeks later, after that point, the patient is presented with fatigue, dark stools, requiring admission for acute upper GI bleed. And I've kind of put this context here, and Allison and Hadley and Dr. Dan and can most, or Georgia can most certainly speak to this, but this is some of the framework around anticoagulation stewardship. And I've circled some context here. And I get, as someone was alluding, there's these micro interventions where we're looking at the patient individually and how we manage that. But I think the conversation here, and I'd love to hear from the panel, is really what are other things that we can do on both a macro level and, to Georgie's point, as we get more advanced as a part of that construct, a personal level. And I think that's where this programmatic development helps secure that we're going to be able to do those things. What is the commitment from our teams, our leadership teams, that we're going to do that? Whether, what the definition of multidisciplinary support is. And one of the comments in the box that says, if pharmacists aren't doing it now, how do we, eventually change that pendulum depending on the region? But more importantly, just what does that team effort look like to do this? And how do we implement that systematic process of care? So, but just kind of based on the case, what are, in hearing from what Allison has said, what are some things that you would think of that come to mind that you could do from a stewardship perspective to prevent these types of things happening to this patient? I mean, there's underdosing, as you mentioned. There's patients that eventually got aspirin put on, quote unquote therapy failure that is deemed because of maybe the underdosing? So what are the systems of care, just to hear people from the panel jump in and kind of think through this?
May I intervene?
Sure.
I'm sorry. Let Hardy.
You can go, Professor Dan. You go ahead.
Hadley, you want to, yeah, go ahead, Hadley, and then we'll go
I'll
to
pick up
Jordan.
it. Thank you. I'll pick up the point, perhaps that I was alluding to earlier, and that is the circle there around data collection, tracking, and analysis. And this can be done on paper records or electronic records in your system or healthcare network across institutions. It might be something that's done within a team or across teams to look at guidelines that are in place, dosing recommendations, for example, appropriate dosing of DOACs according to criteria product information, and to actually collect data on what is happening out there within your institution, patients being discharged home. That talks to the facilitating transitions of care circle with regards to appropriate dosing of DOACs. As Professor Dan alluded to earlier, there's concern around overuse, but even more so underuse of anticoagulation and the resources and problems associated with thrombotic events. Particularly as we've seen from registry data, AF registry data around underdosing of apixaban, and collecting data on patient outcomes. So how often are we following guidelines and what's happening to these patients, and then presenting that information to clinicians or medical or surgical units that are concerned about DOACs being used at the appropriate dose, or perhaps that are not doing as well with respect to guideline adherence. And data is king in that sense, and be able to then drive change to ensure that guideline adherence is improved. And that's a lot of the work that we do locally. It's small bite, it's small retrospective reviews. It does take some time, but it's important to be able to convince those who may have some anecdotes or clinical concern, but actually, coming back to the objective data and clinical outcomes, and presenting that is at high levels is important, I think.
Jordan?
Let me, first of all, very sincerely, Craig, I thank you very much for this case. You may wonder why I'm thanking, because believe me, I encounter such a type of case at least 5 to 10 times a week in my clinical experience. So first of all, let's number the mistake made in this case. First, and I emphasize on it, is the association between an anticoagulant and an antiplatelet, which is very clear specified in the European guideline for atrial fibrillation from 2020 and also for 2024, that it should represent more an exception than the rule. So let's say in my humble experience, I'm only a doctor among others, from 10 patients, maybe one is indicated for such therapy, and especially in the acute cases, and I don't want to discuss this different case. The second mistake, important mistake, is a low dosage in apixaban. You know that in the Aristotle trial, there were 4% of people on low dosage, and we know now in practice more than 40% are on low dosage, which represents practically that we are not understanding the things. Because a patient does not encounter the two criteria for the low dosage of apixaban: age, weight, and creatinine clearance. And the third mistake, which is most sensitive, in my opinion, is the intention to change the oral anticoagulants once the patient had a stroke under anticoagulants. There is no evidence in this sense. And it demonstrated that the physician does not understand that the problem is a patient with a lot of risk factors, and the anticoagulant is not reducing to zero the risk of the stroke. Now, coming back to the stewardship, where the team and the multidisciplinary effort is indicated. Probably less in the cardiology department, because I need to presume that the cardiologists are reading the guidelines. I'm not 100% sure, not at all, because I encountered a lot of such mistake in cardiology departments, but especially in the family doctor, because this is practically the root of the medicine, and in internal medicine and other specialties. Here, we need really to have a common effort to implement the data, like the stewardship Dr. Allison told us before. Unfortunately, we have guidelines which are not in concordance. And maybe for the second case, I will discuss what is the guideline of the cardiologist regarding the antithrombotic treatment and the guideline of the anesthesists for the same treatment around the surgery.
And to the point that Hadley was looking at, and the stewardship, and to everyone's point, having that data is helpful. And to your point, Georgie, is by having these dashboards and coming up with a process where you're collecting this data and providing that feedback, it does two things. It lets people know about their performance, but it provides an opportunity for that education of what the guidelines state. Here's what we need to do, and anybody can most certainly do that, and depending on the effort of them. And just for the sake of time, we're going to jump into the second question, as you alluded to, is we have a 65-year-old male with atrial fibrillation, a CHA2DS2-VASc score of 3 on warfarin for the past 5 years, and I forgot to put the years in there, but is due for a screening colonoscopy. He's deemed an average risk for colon cancer with negative screenings at age 45 and 55, neither requiring polypectomy. The paraprocedural bridging anticoagulation plan was to hold warfarin for 5 days and bridge with enoxaparin 1 milligram per kilogram twice daily before and after procedure. And the patient develops a nosebleed 1 day prior to the colonoscopy, requiring ED visit and resultant delay of his procedure. And so the question here, and kind of talking about all the things around paraprocedural management, for example, what do you think in terms of stewardship? And I've circled some of the same things, but just the management of these patients, and what do we need to do from a stewardship perspective, or how stewardship principles apply to helping address these issues?
I'll jump in here, Craig, really quickly. I think I just want to point out that I love the way that these circles are overlapping, because I think it emphasizes the point that there's no one single component to stewardship. It all has to be done in tandem. And in relation to this particular case, I think a couple of things are particularly important. One, I would say, is, and this gets back to Georgie's comments, education of clinicians that are involved in the management of these patients. I mean, I think, I have a pretty high degree of confidence that cardiologists are familiar with, antithrombotic literature, et cetera. I don't know that all clinicians are, though. And, there's guidelines out there that would state, in this case, we shouldn't even be interrupting anticoagulation, and definitely not bridging, because we don't have any good evidence that bridging is beneficial, particularly in low risk thrombotic situations. So we need to not only make sure our clinicians are educated on the most recent evidence, but we also need to empower our patients to be able to advocate for themselves and question the clinician and say, is this the most appropriate plan, et cetera, for my particular situation. The other thing is implementing systematic care. And that gets back to Hadley's point of having really clear evidence-based protocols and clinical decisional support upstream, because that affects shared stewardship across practice sites, and is just a really important way for us to try to optimize safety for the patient.
In my opinion, this case was an excellent example of illustrating the necessity of the stewardship. Because in my opinion, the focus of this stewardship should be maybe less, not at all, but maybe less the cardiology specialist, but all specialties dealing with anticoagulation with their patients. So this case raises a problem which is very sensitive. Two problems. First, interruption to anticoagulation, and Dr. Allison told about this, very clear, very clear in guideline, but we should apply the guideline. And second, which is also sensitive, is a bridging therapy. Sir George Pickering said 100 years before that unfortunately doctors could not choose between one or two. So it should be very clear that the bridging therapy is not indicated, even in gross surgery, not in this case, in which is not indicated interruption, as Dr. Barnett said, but it's not indicated in a great majority of the patient on surgery, but there are exceptions. And these exceptions should be known. For example, the patient with prosthetic valve deserve bridging therapy during the surgery because it's a risk of thrombotic event, even if we decrease the anticoagulation of warfarin. But the case is very clearly illustrating the necessity of this is a case, in my opinion, the gold example why we need everything which was said today about the holistic approach, a multi-team approach, and the spreading the information to all dealing with the patient anticoagulated.
Yeah, and just one more quick comment to that case is, another really important way to apply stewardship to this would be to just question why is the patient still on warfarin? Is that still the most appropriate therapy for that patient? Because if we can get them onto something like a direct oral anticoagulant, it could greatly simplify their care, particularly around any potential invasive procedures or surgeries.
And just go ahead, Hadley. Sorry.
Yeah, sorry. And great point, Alison, because that's the part, it's the next step around reviewing the patient's anticoagulation and focusing on that. Whereas, the surgical team will be focused on something different, and anesthetic teams will be focused on something else. So you're bringing in other teams that can help improve the care of the patient. And it's another example where don't necessarily need an anticoagulation stewardship pharmacist or team, but you can have systems in place to have pre-admission clinics, clear guidelines to be followed regarding bridging or not bridging patients to reduce complications such as bleeding.
Real quick, go ahead, Georgie.
So sorry, Greg. There are two questions I find very interesting on the chat. First, because the answer is different. The first question, which DOAC is safer? I want to be very honest. Despite I know hundreds of publications demonstrating that one or another DOAC is safer in comparison with the other, probably with the exception of the rivaroxaban, in which there is a consistency of a little bit higher hemorrhage than dabigatran or apixaban, and it is logically because a one-day dosage. There is no definite answer, at least in 2025, that one DOAC is safer than another regarding the approach in surgery. This is very clear. But the second question is that it's a little bit more tricky for me. Which DOAC is easier to manage? When you think to this, in your mind is the reversal agent. And from this point of view, dabigatran has the most convenient reversal agent because of the pharmacological properties, rapidity of administration, and availability.
And we're running near the end of time. I just want to briefly, and Allison or whomever can speak to this. Obviously we've talked a lot about DOACs and maybe some outpatient orgs, but clearly stewardship is very applicable to inpatient efforts. And can you briefly touch on that? And then a little bit about the future of, and you can lump this in there. Obviously, we know there's on the horizon other anticoagulants. Do you think, or newer anticoagulants, factor 11A, do you think stewardship changes or goes away, or is it always something we're going to need? And I'll let you jump to that before we close. So,
Hadley, you want to take that?
I'll leave it for you, Dr. Burnett. Thank you.
Okay. All right. Well, Craig, thanks for highlighting this publication. I think this is one of the first and a really good example of embedding standardized systematic processes into the EHR to drive standardized perioperative management. This was done by Kelly Rudd, who's a pharmacist in Oklahoma, and other colleagues. And it encompasses all aspects of anticoagulation stewardship. I think one of the most interesting things about it, and again, this gets back to Hadley's point about, it doesn't have to be a pharmacist doing it. This initiative actually relied heavily on our nursing partners to be able to drive these processes. And through this, they were able to demonstrate more standardization and reduction in variation from institutional protocols, which will culminate in improved patient outcomes. Do I think stewardship will continue to be needed after the advent of the factor 11A inhibitors? I actually think it's going to be needed more because it's going to get more confusing. We don't know what role these agents are going to have in practice. We don't know if they'll be, combined with other agents. We just don't know yet. But I would say it's definitely not going to reduce the need for anticoagulation stewardship.
very good. Thank you all. And that's all we have time for today, I'm afraid of. We could probably talk hours on all this and all things anticoagulation, and I appreciate everyone and the great conversation. I'd like to remind you that today's recording will be shortly available on demand at www.iscpcardio.org and accessible to the ISCP full and associated members exclusively. So please consider joining ISCP or upgrading your web membership to watch this. And all webinars from A to Z of our CVP series will have very interesting sessions in our e-learning sections waiting for you. Please scan the QR code you see on the screen to go to our main links and learn more about ISCP and on social media. We have several historical claps and other items that we've done related to anticoagulation that are useful tools and discussion points as well. At the end of this webinar, you will be invited to fill a brief feedback survey. It will only take 1 minute of your time, and the information you can provide is valuable to us. It's anonymous, so please complete it as soon as we finish here so you can request your certificate. Before we go again, I sincerely like to thank our faculty for their fantastic contributions. Dr. Burnett, Dr. Dan, Mr. Hadley, or Mr. Rotz, thank you so much. And finally, our team wants to thank you, our audience, for joining us. We hope that you have found this a valuable insight, and we'll continue to explore and consider ways that anticoagulation stewardship can be impactful across your practice or institution, whether you have pharmacists or not, and or do you start thinking about advocating what that looks like. So I think it's worth a larger conversation. Make sure you join ISCP to receive our newsletter and updates on the Society's educational activities. And of course, follow us on social media at ISCP Cardio, the easiest, most effective way of staying up to date on all ISCP events. Thank you and goodbye. Thank you all.